my name's Kirsten Moore. I'm the team leader of the care and assessment team. I'm based down here in Uist, but I cover the team which is Western Isles wide. So that's Lewis, Harris, Uist and Barra. So that's me. In terms of the team, obviously that team is made up of social workers and social care assessors. So obviously the clue is in the title to what we do. We are a care and assessment team. So we are the people that meet with the public, with clients, and we assess them for their care needs. We would then put forward a plan that's then discussed with the family and the client, and then we hopefully put those services in place, or we work with the family to put in place services that meet the needs.
Could you just outline some of the care packages that you have?
In terms of if we put together a support plan with a client and a family, what we're looking to do is meet those needs, meet those outcomes that have been identified in the assessment. So what we'd be looking for would be whatever we have assessed, we'd be looking at how we're going to meet that. Now, some of those needs might be met by the family, some of those needs might be met by formal care from the Corla, and some might be needs that are met by third sector or voluntary agencies. So it's very much in discussion with the client and their family about how we'll meet those needs. So it's all based around the assessment and the assessment outcomes, and depending on what they will be.
Yeah, scenario A, my mum, hip operation on both hips. How do we access care for her? What's the first step? What happens?
Well, that would depend. Yeah, that would depend on, yeah, you've just said that. So your mum's in hospital. So we actually have a social care assessor based at the hospital. So what would happen would be the ward staff would identify whether somebody is likely to need some support on their discharge. So that referral is obviously done before the discharge date is even discussed. So, you know, they're already highlighting that somebody might need support depending on what their situation is at home. But if, for instance, they lived at home and they are identified to need some support, then they would put a referral into the social care assessor at the hospital, who would then carry out an assessment with the consent of your mum. That's quite important that that is in place, because obviously we can't complete assessments unless somebody has agreed to that. So we would carry out the assessment alongside the client, identifying what their needs are and what their outcomes are going to be. So in other words, you mentioned about hips, so we'd be looking at mobility, how they would transfer out of chairs. We would have the assessment done by the OT and the physiotherapist in the hospital as well. That would add to our assessment. And what you would have at the end of it is a holistic assessment about how those needs will be met, because once we've completed the assessment, we then start discussing the plan. In other words, who's around to help meet those needs. So your mum might identify that family members coming home to help the discharge, might identify that they might look for the local authority to support with that, or they might identify other options to meet that need, depending on what the assessment was. So what we look at is through SDS. So there are 4 options within SDS, from the support being provided through a direct payment, whether that's through the local authority, whether it's through a mixture, and then there's an option 4 as well. So we would go through all of those options with the client and the family, if the family want to be involved in that as well, and we then formulate a plan. So it would really depend on what option was identified by the family member in terms of how that need's going to be met once the outcome and the need has been identified. Self-directed support. It's about helping people identify how best to meet their needs. So it's really giving the control over the provision to the client, and they can choose how to meet that need going down. Most people usually opt for an option 3, which is the local authority, because although Although there are, I suppose, there's a lot of worry about local authorities doing care at the minute, because I think there's a general knowledge that the local authority is having difficulty providing packages just now. So a lot of people are already thinking, well, actually, I might actually ask for that in a budget and use the money and find a carer myself, and I'll have more control over it. So they'll control what time the carer comes in, who the carer is, and it gives much more control to the client. But then a lot of people also like the fact that the local authority will organise it and find carers for them. So there's obviously options for people. There are choices, but people sometimes just automatically think care at home are going to be the providers, because that's the kind of traditional model we've always had. But SDS, self-directed support, was meant to really give people more choice, more options in terms of how their needs will be met.
Say, for instance, somebody is in hospital with quite a serious condition. The habit in the Western Isles is to underplay and understate your need. And so how to what extent would you push and help somebody, you know, they're in denial about their operation on their eyes, on their hip, on their knees? To what extent would you push and say, you are in a situation, you do need intervention, or would you, or do you tend to hold back?
If someone is deemed to have capacity, so in other words, somebody has told, a medical person has told us that somebody has the ability to make decisions for themselves, then we very much have to work with that person. So really, we have to, and that's why I'm talking about outcomes as opposed to just what somebody needs. You could identify needs quite easily with people by just meeting with them and identifying what they might need or what you feel they might need. But the whole idea of the assessment is that you work together with someone, identifying agreed outcomes. So in other words, that's about us agreeing what we're going to work towards, not just what I think somebody will need. So of course the conversations will very much be about, well, I'm aware that you have difficulties in this area or challenges in that area, but we could not, for instance, put a service in place for somebody that wouldn't agree to it. We will do all we can to put things in place to encourage people to take support, but we would be very much working alongside them and reviewing things very quickly, and hopefully building packages in that people will then accept. And it depends on why somebody won't accept something. It might be because they are frightened, or they're just wary of having people in their house that they don't know, or they, as you say, they might just be in a stage of denial in their illness, and therefore that needs a bit of, I suppose, perseverance and working alongside somebody. But we cannot just foist services on people and expect it to work, because it just wouldn't work. They would probably reject it as soon as people turned up at the door. So working alongside is very much the key to this.
So they might actually reject the offer.
Yes, and it happens often. That we'll actually complete assessments and put in place a plan, and that plan actually might fall by the wayside because it might not be what somebody thought was going to happen, or they might just have agreed initially, but then once they're maybe feeling a bit better, they feel more able. So it is very much about that process of getting alongside and reviewing on a regular basis. So yes, if somebody has the ability to make their own decisions, we have to listen to them.
In case of somebody's health continuing being at one level on discharge, and maybe just a moment for a period after just discharge, is there ongoing observation? Do you monitor them for deterioration, and then do you adapt what you give them? Does it?
Yeah, I mean, what happens is there should always be opportunity for review. We have standard reviews which we aim for. Obviously, because of the demand on our services, we might not be hitting the targets of our reviews as we should be, but we really do aim for on discharge, either into the community or the social care assessor will continue to follow that person into the community, and we usually review it 4 weeks, 4 to 6 weeks certainly, to make sure that that discharge from hospital has gone well. Obviously people have the ability to phone us if things after 1 day, 2 day, 3 day, they can phone that social care assessor, that person will stay with them for that period of time. So they've got the ability, or the family have the ability, to phone that assessor to discuss what's working or not working, because as well as things being different, they can also be, people can also do very well when they go home. It's not necessarily a negative thing. Sometimes what we find is when people go home to their own environment, especially maybe people who have had their capacity has perhaps been affected, we can find that actually they do better at home because they recognise their surroundings, they know where everything is, and they feel more settled and more relaxed at home. So we actually try and do as many assessments in people's own homes as we can. We do recognise that when somebody's in hospital, that's the starting point a lot of the time, but we do try and endeavour to actually assess people at home, because we found out, we know we just get better results. The care plan, the support plan tends to be a better plan when it's done that way than in hospital. But we recognise we can't do that all of the time. And then we've got the ability to tweak the plan to fit whether things have deteriorated or whether things have got better. So there's always that ability to change things.
Being in hospital, the first point of accessing care like this, what if somebody's health and capacity to care for themselves was deteriorating gradually and they were just at home? How would they get in touch with you and access your services?
There can be many points. So in other words, an allied professional can make a referral to us with someone's consent. So a GP, a community nurse, a physio, an occupational therapist, anybody at all that you can contact with, you can ask them to make a referral on your behalf. And the other way is you can self-refer. So you can phone into the social work department. So in Lewis and Harris, that would be the 01851 822 708 number. And we've got a duty system that's there 9 until 5:30 every day, or 9 till 5, I think the phones go off. And down here in Euston Barra, it's 01870 602 425. Again, the department will take your name, they'll take the referral, so you don't need to go through an assessor at that point in time. Your admin support can take your referral, and in Barra you contact the council offices there. So a simple process, not talking to too many people, just ask for the social work department and give your details. But the consent is the important bit. Sometimes people get caught out because they believe that if they phone in, they can make a referral, but we will ask the question, has the person consented to the referral? Because that's really important. Because otherwise what happens is we get in contact with the person and they just say, I don't know what you're talking about, or I haven't agreed to that, or vice versa. And at that point we would have to end the referral. So it's much better to work alongside somebody to get their agreement to contacting us, because it can be a crisis point for people to get to social work. So it can be quite a scary experience. Most of the time it's positive and people want help or are at the point where they need some support, and therefore they're more than happy to involve social work in that discussion.
The levels of domestic care that you give, when my mum was a home help for a while, and she used to cook, prepare meals and spend quite long periods of time in the homes of her clients, also providing, companionship. Give us a wee side-on glance at what sort of levels of intervention you would actually commit to or deliver. Yeah,
things have probably changed quite a great deal. I began my career as a home carer many years ago, and like you say, things were very, very different then. Things have changed to the degree where eligibility for the service has changed, probably many times over. And in my time, I can remember I was lighting fires. That was a day when even sheltered housing had open fires in those days, and I more or less had to move from one house to the other. Again, a great deal of the time it was domestic tasks we were doing as home care then, and it was rare to do personal care. Now that's been turned on its head, obviously, with the known position that people are cared for best in their homes, and that is what people want. That means that the demand and people's needs in the community are a lot higher than they've ever been. So the days of doing fires, the days of doing any kind of domestic tasks are gone, and more or less our carers are doing personal care, which is what you need to have to be eligible for our service. So in terms of what a care at home carer would be able to do, would be very much dependent on needs, but the maximum that you can get in a day would be 4 points of care. And that would be usually spread out throughout the day. So you would have a morning, a lunchtime, a tea time, and an evening time. And you can think what the tasks would be if somebody is needing some support with their personal care. That would include washing and dressing, assisting to the toilet, and also perhaps preparing and heating a meal. So that's what would be the 4 points of care. So all of those basic care needs would be covered in those visits. Sometimes you need one carer, sometimes you need two, depending on the mobility and the transfer needs that that person might have. So you mentioned particularly meals. So if, for instance, the client has been identified as needing a meal as well as personal care, what we would do would be heating and preparing a meal. So we wouldn't actually cook a meal. What we would do was we expect clients now to have either frozen meals, or I think McLean's meals is very popular. So we kind of expect people nowadays to have microwave, but it's not always the case. We can heat up meals as well, but it's about time. So there's a certain amount of time that's allocated for a meal. That's where we would it's called prepare and heat a meal. So either families usually are making meals and freezing them, or people are buying pre-packed or ready meals for the carers to heat up. They're on about the tasks of traditional care at home, and that was about companionship. What we look at now is the role of the third sector. So up in Lewis and Harris, Crossroads would, if in the assessment it was identified that somebody is isolated and would benefit from maybe someone sitting them for a wee while, or indeed that they would enjoy or would benefit from day services, we would go down that route of, you know, what's out there in the community. It's very much community led. Different areas have obviously different projects on the go. There's some good projects down here in Uist, the Cunha project, which is very much about supporting carers and clients who have dementia. And it obviously supports them to come along and have a meal and have some company, and they do lots of things to help people's memory and things like that. Again, in Barra as well, there's the Core Vara, which again is an excellent day services and obviously home support service as well. Up in Lewis and Harris, Crossroads are very good. So there's a number of different things we would pull into that support plan, depending on what the need is. We can also provide support in the home if somebody doesn't want to go out, perhaps through mobility or just that they're anxious going out. We can maybe look at support in the home for them, or even respite for their carer in the home or out with the home. So lots of different things to meet the needs of the cared for person as well as the carer, because I think carers are extremely important in the current climate we're in. We've seen over the last year unpaid carers really doing over and above, especially when day services weren't able to operate for a period of time there, and they're still restricted because of distance. And we saw a lot of the services go to a kind of minimal service. So I think we're very aware of supporting our carers out there in the community.
Yes.
Spending's very good, and even through lockdown, although they couldn't visit people in their homes, they were doing phone contacts. Obviously that doesn't work for everybody, because some folk, depending if they have a hearing impairment, but certainly there was lots going on. People being, you know, really thought outside the box in terms of keeping contact with people.
Yeah.
But it's challenging times just now, there's no doubt about it. I think you're probably picking up that you know, there are waiting lists in every area across the Western Isles just now for care at home in particular. Waiting list for care home placements. And COVID has really just made that, it just exacerbated that problem, because it's about staffing. It's about provision of services. It's the care crisis we have in terms of finding staff, in terms of finding carers, is very real, and we've been very, I suppose, lucky in many ways that families have been able to help out as much as they have, and the reality is we'll be expecting families to continue to help out their loved ones, because we're definitely struggling to find the staff to meet the needs of everybody in these areas.
Yeah, on the point of there's another one of the bullet point. Another one of my questions was care homes and accessing a care home. How do they cross that threshold and get into a care home?
It begins with that assessment. Like everything, it all starts with assessment, and that assessment comes from everybody, so that we'll have the family, we'll have the cared for person feeding into that assessment and getting their views. It's a huge decision to make, to think about a care home. If someone has capacity and they're able to, sorry, there's a wee fly that's annoying me. So if, determined wee thing. So if someone has capacity, but obviously their needs are so high that they are unable to stay at home, they have 24-hour care needs. As I explained earlier on, the biggest package we can put in place in the community is 4 points of care. Then if somebody's needs, you know, go past that point and they have overnight needs, and they have a lot of families will maybe stay over with their loved ones and support them through the night, but not everybody has that. And as soon as somebody's needs have gone past the point of being able to be supported in the community, then we start to consider and talk about a care home. But as you're aware, that comes with it lots of decisions in terms of paying for a care home, in terms of what that means, and that's all part of the assessment and the discussions that you have in terms of, is there any other way that the needs can be met, and if not, then start looking at care homes. As you know, we've got a number of care homes in our estate, and we've got local authority care homes as well as private care homes, but even the private care homes it's local authority that purchases those beds. So in other words, if you're on the mainland, for instance, you would maybe have choice, that if you reached a certain age and you felt that you didn't want to stay at home any longer, you could access a care home that you can purchase. But in the Western Isles, you can only access a care home once you've been assessed as needing a care home. You could go and access a care home on the mainland, you know, and whatever, but you couldn't do that here. You have to have an assessment that identifies you have 24-hour needs to access the care homes here in the Western Isles. So that discussion about assessment and needs is very important with the social work department. Now, it might be when you actually sit down with the assessor and discuss what your needs are and your worries are, you can maybe meet those needs in other ways. But if, as I say, the needs are significant and cannot be met, then obviously our assessment would probably be a residential home as well. And then it's all about, you know, discussing the finances of that, and in some cases the legalities of that, because if somebody doesn't have capacity to make that decision, then we need somebody in the family to make that decision for them. And sometimes the difficulty is that somebody has not put that provision in place beforehand to actually allow someone to make decisions for them. So we talk a lot to people, and there's quite a lot of promotion out there in communities about future proofing. You know, we talk about it when we talk about building houses now, when we're talking about planning, you future proof your house. We should also be future proofing our you know, older days, and that includes thinking about who do we want, if the need arises, who do we want to make decisions for us. And it's very important to do, very simple to do, a bit like doing a will, but unfortunately people tend to put it off till it's too late. But we are seeing that more and more people are getting better at thinking about it and putting it in place. So it definitely helps for that planning to happen if these things are in place. So much easier if we have somebody that can make decisions, or has somebody to make decisions for them. Because then what we're looking for them to do is say, this is what they would want, or we've had a discussion about this, and this is where we've talked in the past about what they want to happen. So you've got somebody very clearly making sure their views are heard.
The direct payment, is that means tested?
I don't know. I don't think it is. Nope.
So it's just if you're in need, you get that direct payment.
What happens is, if you have your assessment, your needs are identified, and you decide that you want to have control over how that need is met in terms of your provision, you will be given a budget to manage that. I mean, the key with direct payment is that you have to be able to, you become an employer, really. So, I mean, there's lots of support out there to help you to set a direct payment up, because you need to obviously understand that, you know, your staff member, or your PA, as we call them, your personal assistant, you make sure they have holidays, you know, you make sure you're paying them a wage, and you make sure they're trained and supported. Direct payments are very good for a lot of people, but there are rules and expectations with the direct payment, and that's the bit that you have to understand, or have somebody to do that. Direct payments, you can't have, it sounds like I'm saying lots of negative things about what you can't do. You can do lots of things with a direct payment, but there are rules such as you can't have your power of attorney managing your direct payment or being your PA. So simple things like that, and also family members. So you can't pay your family member to be your carer. So unless they're, you know, further removed in terms of the family, or unless there's exceptional circumstances. So again, that's where that discussion with the social care assessor is really important. And again, the review after the direct payment is put in place is really important, to make sure that somebody's understanding what they're expected to do with that direct payment, what they can spend the money on, because the direct payment can only be spent on what's been assessed as an outcome. It can only be used for the need that's been identified. So you can't get a direct payment for personal care, for instance, and use that money to then go and buy, even if it was a piece of equipment for your cared for person, because that's not what it's for. It has to be used for personal care. I think the biggest challenge I'm seeing for people who are choosing to go down the option 1 direct payment route is finding PAs. So finding a personal assistant to actually take on that task. And again, it comes down to this demand on staff. Staff are being robbed from one area to go and, you know, to go and work somewhere else. So especially people who are trained. So you quite often find somebody was maybe started their career in a care home, or maybe worked as a care at home carer, and then maybe gone and been private carers, and before you know it, they're all robbing people to take away that carer, really. But there are some people that make their living out of being PAs. And sometimes it's other, more distant family members that are doing it, depending if a carer can be found. So, but my understanding is direct payments are not means tested.
Yeah, I was on the mainland for a while, and some people do make their living out of being PAs, actually.
I think there's definitely a need out there for PAs, good PAs. I would definitely say so, especially ones that are trained in. And I think in the area of, learning disabilities and working with children, I can see great benefits to being able to be flexible and accessing the community. All those times. I think it can be definitely a game changer for a lot of families.
You mentioned staffing a few sentences ago. Can you give us a wee glance at the level of there's people on the ground going around in cars who are going into people's houses and delivering the care. Can you just give us a wee glance at who it is that does what, how many of them are there, and the kind of the three?
You're in an area that's not mine, I'm afraid.
Okay.
Obviously, I'm aware because my team, the team I work within, we obviously we request the care, we request care at home to go in or whatever. So we're very aware of supporting families while they're on a waiting list. We also have a number of clients across the islands who are perhaps in a care home awaiting points of care. Now, we haven't been in that position before, and that was really a new way to manage really discharges from hospital, because what we were finding during COVID was there was obviously a huge need to clear out hospitals in anticipation the hospital would need to accept COVID patients, and that was going to be what we deal with. But we've continued that practice on, because what we've found is there are some people who, while they wait for their care at home package, are not safe to be at home and they don't have anybody else to meet those needs. So they have had to go into a care home and await those points of care. And depending on the area, that can be a very long wait indeed. And that's about staff. That is about finding staff in those particular areas. Now, I know the service that provides care at home, the resources side of things, they're bringing in agency staff. They're always trying to make sure they're using the carers in the most productive way. So in other words, they're not going long distances, and we're trying to make sure that we meet as many needs as we can. But it's extremely difficult when there's such large care packages out in the community. So we're always looking at how we can make things better, how we can try and meet as many needs as we can. But I think the general feeling is we've been in crisis for so long, and with COVID, all you need is a positive test on one carer or a family member, and that can wipe out a whole team of carers, and therefore reduce one area down to no care at all. And that's where families have to sit in. So it's very difficult at the minute. It really doesn't take much for that call to families to say, can you step in while we're awaiting a COVID test or, a period of isolation. So very, very challenging times. But that is my kind of partner services, the provider side of things. So I couldn't tell you how many, well, I know we're running a waiting list, but I don't know what the numbers are at the moment, and I don't know what the numbers are in your area.
Particularly on assessing, how many staff do you have who have the role of assessing somebody's need? Do you mean up in Lewis and Harris? Yeah, up in Lewis and Harris, yeah. Would there be somebody in the hospital, somebody in...
Yeah, we've got one social care assessor in the hospital. At the moment in Lewis and Harris, we have let me have a wee think. We've got 4 social care assessors in the community, but one of those staff members has just left. So we've got 3 social care assessors. And in terms of social workers, which would pick up more complicated packages, we have 1, 2, 3, 4 social workers. So we've got a member of staff who's part-time, who's on maternity leave just now, and her other colleague that shares that post, she's on sick leave at the moment. But we still have 4 social workers, 3 social care assessors. Hopefully going to fill that social care assessor role in the community very soon.
And the SDS payments, is that tiered as to what the condition that's been assessed and need?
No, if you're talking about a direct payment, so in other words, again, it's based around that assessment, and it's not, it would be very much around what you're assessed as requiring. So the individual budget would be based around that. So in other words, depending on whether that budget is made up of day services, whether it's made up of the personal care element, whether it's made up of a carer element to that, what would happen is you would get, depending on what service it is you've been assessed as, that budget will look like. Sometimes it's just the personal care budget that people will get, and then they can use that to buy in somebody to come and wash and dress when they want to get up and get washed and dressed or put to bed at night. So it really would depend what the budget looked like on what services they've been assessed as requiring.
And is the budget based by the private sector's budget, or is that a mix?
Well, because with the personal care, I think my understanding is it's, the reason I'm sounding as if I'm a bit unsure is because things have just increased a wee bit, but it's round about £15 an hour for personal care. So that's what we would give the person who's managing the direct payment, but they wouldn't give all of that to the carer. So they would keep some of that back for payment of somebody else to come in when that staff member's on holiday. So the £15 wouldn't go to the PA, you know, because there's administration fees and things in there as well, and we add that onto the budget as well. If it was day services, what we might be looking at is the equivalent of what day services would cost, and they would get that in a budget to deliver it at home. And with the carer, equally, it would be looking at what the carer would get, and that then we would break that into the budget and then show the client that and see whether they want to choose that, or maybe a mix. They might want the day service part provided by the local authority under the option 4, but keep the personal care under the option 1. So that there's lots of different ways that people can do it depending on what suits them. So that discussion with the social care assessor is really important. I think a lot of people just think that I have needs and I'm going to meet them through care at home, but we need to come away from that and actually start talking about what is it you want, what is it what outcomes do you have, what is it you want to do, do you want to is it important to you that you have much more control over who helps you in a morning when you're ready to get up? Is it the fact that you want to see other people and get out in the community, but day services doesn't suit you? How do you see things suiting you? So it's very much about that discussion about how that can fit. But unfortunately, people are quite tunnel visioned when it comes to how they think their needs should be met, just because it's what they're used to, I think, or they've seen somebody else have their needs met that way. And maybe it's worked for them as well, I think. Certainly when I hear people talk about our care at home service, you know, people enjoy having carers coming in, and they would never think to complain that, you know, they're coming in at 8 in the morning, you know, because they're just that grateful they've got somebody to help them. But there are options to that. You don't need to have a care at home come in at 8 o'clock. If you want to get up at 11, one of the options might be, and you can think you maybe know somebody who would be your personal assistant. Maybe you could purchase that in for them to come in when actually you, but I think that comes down to sometimes just the mentality of older people. They're just that happy and grateful to see people. So that's why I'm saying dialogue and talking through options is so important.
Yeah, I'd imagine a PA would be more attractive to younger people and more with it people.
I certainly think, I said that earlier on to DJ, individuals with learning disabilities younger people, children, it can work really well. Yes, older people, I think it's the management of it. It's the worry about, thinking, how am I going to actually do this? What do I have to think about? So maybe if they had a member of their family that could help them do that, it would work really well. But I think sometimes family members also just think, well, if the local authority has that service and that's what I need, I'm just going to go there, and if it takes 6 months to wait for it, then I'll wait, but I think that's becoming more and more difficult for families, especially for those that have family on the mainland. And because of the last year, a lot of families haven't been able to come up like they would normally do. Usually we see a lot of families coming home. That tends to be when we get a lot of referrals or people phoning in worried because they've come up to see their loved one and they've suddenly realised how things have changed. But in the last year, a lot of people couldn't come home, and therefore they were very anxious and worried, and relying very much on the care at home service to provide for months on end, without ever coming and supporting that or seeing what was going on. So it's very difficult when you're far away from your loved one.
If it ever came down to going down the private route, certainly for the older people, I think the care service should help them a wee bit more if that's a route they want to go down.
Yeah. I think
maybe hands on until at least it's established.
I think it's just so difficult just now, especially in certain areas. I know in Harris, for instance, a lot of people were looking at going down the private and just couldn't find any way. They were, using the list that's held with the forum, the carers forum. And they were exhausting that list and more, going to the point where they were approaching neighbours and friends and saying whether they would be interested in being carers. So I think what we were finding was a lot of people were getting quite frustrated that even going down the option 1 route, they just weren't able to find somebody to do the care. So it is, like I said earlier on, the crisis we have is a staffing one across the board. I don't think there's any part of the island that doesn't have a crisis of finding people. I know there's lots of different approaches that are being taken, whether that's to do with affordable housing, whether that's just to do with, talking to people about careers, as opposed to, people seeing that these are jobs that you just do for a wee while and then move on. It's about making it attractive. And I think, just looking at the pay and conditions and things, that's always been looked at just to try and encourage people to come and do these jobs, because there's one thing that's absolutely sure: we're going to need more carers in the Western Isles, because we know the demographic, and we know how it's going to be over the next years coming. So we need to really work hard to try and encourage people to come and do these jobs. And they are good jobs to have. They're very rewarding jobs. As I said, my career started in care at home and working in care homes. So I would definitely, if I met somebody who was looking for a career change or a new career, I would certainly be promoting it as something that's very worthwhile. In terms of the points of care, generally we have a guide to how long a task will take. Obviously that can change. If somebody's got poor mobility, we would obviously factor that somebody might take longer, but we still try and aim for certain times for tasks. But again, it all comes down to that assessment of what you're requesting. So there's no such thing as a standard time frame, but our carers don't tend to be in for longer than an hour. 3/4 of an hour seems to be, the kind of top end of how long somebody would spend. Obviously, if the care packages get much larger than that and involve 2 carers, there might need to be agreement with that at a higher level at a resource panel, if care packages are at a high end where that's being agreed, because obviously we have to have across the islands the same service provision. We can't have somebody sitting in one place with a huge care package and that not being provided down somewhere else. So we have to have these eligibility criteria in place, and obviously that means we have to make sure if it gets to a certain level that is then looked at and explained why it's at that level and whether that's something we are going to pay for is the bottom line to that.